If you're trying to conceive and feeling overwhelmed with fertility advice, then this podcast is for you. Welcome to Don't Tell Me to Relax, your fertility podcast and antidote to unhelpful fertility information. I'm Hannah, a fertility acupuncturist, teacher and campaigner for better fertility education. This podcast aims to empower and inform you about your menstrual cycle and fertility. It's basically all that information you didn't get in sex ed at school, with the aim of improving your understanding of your reproductive health and optimizing your fertility. Hello everyone, welcome to this week's episode of Don't Tell Me to Relax. I am joined by the very lovely Kathryn, who I can see wearing a gorgeous green top. Kathryn is an embryologist at the Lister Fertility Clinic and has very kindly come in and spoken to our Facebook community before and also to our team, because embryology is such a fascinating part of fertility and such a, I don't know, I always feel like completely in awe and just blows my brain whenever I meet an embryologist, because you are so brilliantly clever and amazing at what you do. And we're really grateful that you came on and you've spoken to the community group and that you're here on the podcast today. So, Kathryn, would you like to introduce yourself, say a little bit about where you work, what you do, and also your background, like how do you become an embryologist?
Hi, Hannah. Thanks for having me. It's always a pleasure to chat to you. I'm an embryologist at Lister, a senior embryologist, and I am also the genetics lead there. So I manage the genetics program, and anything to do with the genetic testing, I kind of keep it running and keep it going. So I've been in embryology for about 20 years. I started off at university and just really enjoyed the reproduction side of things, and found it really interesting. And actually, my professor at the time said, go off and get some work experience in London, go and sort of ring around the sperm banks and see if you can get a bit of experience there. The plan was to go back and do a PhD with him, but I got a job at one of the big clinics, ended up just really enjoying it, and they offered me a trainee position, and it kind of went on from there. Yeah.
It always blows my mind when you say that you've been in the industry for 20 years, because you literally don't look old enough to be around.
You are too kind.
Today, because you have a focus on genetics, that I thought that it would be really good to talk specifically about genetics, because it feels to me, and I don't know, obviously, because I'm not an expert, but it feels to me like it's an ever-changing world. And it feels like the technology and the processes have changed so much in the last 5-10 years. So I thought it would be good to talk a little bit about that. And so what I'd like to start with is to talk really about this idea of sort of, what are genetics? Like, what is it all about? And why is it so important? Like, if you didn't understand anything, sort of tell us the basics of what genetics is.
So it's important to point out that I'm not a geneticist. I am the genetics embryologist, but as you know, the genetics field is absolutely massive. So I specialise in embryology, looking at the genetics. In terms of IVF and in terms of fertility, every individual will need to have 23 pairs of chromosomes, and they're numbered 1 to 22, and the 23rd pair of chromosomes is the sex chromosome. So either XX for a female or XY for a male. So every healthy individual needs to have that complement to sort of grow and develop and to have healthy offspring. When you get too few or too many chromosomes, that's where things can go wrong. And that is the main sort of cause of miscarriages, of implantation failure, and things like that. There are very few chromosomal abnormalities that can go to term. So I think one of the most common ones is what we call trisomy 21, where an individual has 3 copies of chromosome 21, and that's, as most people know, a Down syndrome individual. But the genetics are important to make sure not only that you can function normally, but that you can go on to have a healthy offspring.
Yeah, because we hear that a lot when people have miscarriage, that often people are told it must be there was something genetically wrong with that embryo developing, which is why it stopped. And am I right? That is still the most common cause of miscarriage?
It's the one of the major reasons that people miscarry. Yeah. But it's important to remember it's not the only reason. So although it's easy to blame the embryo for being chromosomally abnormal, it's important to remember that there are other things that can be causing you to miscarry.
So can you tell us a little bit about karyotyping? Because again, it's something that I don't hear that much about, but having done a little bit of research into it and having worked with some people through clinic, it's something that I think is really, really interesting. So could you explain what karyotyping is and the testing is around that?
So karyotyping is where we take a blood sample from a patient and send the blood off for analysis to look to see whether that patient has got the right amounts of chromosomes. So as I said, you need to have those 23 pairs of chromosomes. There are a very small percentage of people walking around in the population that will have what we call a translocation. So it could be that two of the chromosomes, so they've got all of the right chromosomal information, but two of the chromosomes have either swapped over a little bit of genetic information, or two of the chromosomes are effectively kind of stuck together. And so for these patients that have this, what we call a translocation, they, as I said, have all of the right genetic information in their karyotype, but it's slightly, they've got a rearrangement. So when they come to have offspring, some of the embryos that they generate will have what we call an unbalanced translocation. So it will have the wrong amount of information, the wrong amount of chromosomes within that embryo. I was just going to say that there are a couple of other sort of things that the karyotype might pick up. It might be that they have either a duplication or a deletion of one of the chromosomes as well. So that's one of the other things the karyotype detects.
And so does this mean that so I presume when you do the blood test, you do it for the male and the female?
Yes. Yeah.
And then what, if something comes up, can you still, is it that every single time you try to conceive and every time an embryo is formed, it's going to have problems? Or is it just the majority? Like, is it a blanket kind of, this is not going to happen if you've got like one of these issues is identified? Does it mean it can never happen naturally? Or does it just mean that it's more likely to happen?
That's a good question. So obviously there are so many different translocations out there and different combinations that can occur. But generally, if you have a translocation, you can come to us and we can do a process called PGT A, where we can do the genetic testing on the embryos, and we can then select an embryo that is either completely normal for the chromosomes or has a balanced translocation. So effectively has the same kind of karyotype as the parent. And then, yeah, certainly those embryos can go on to be implanted and have a healthy live birth.
In terms of like who would you do this test on? Who would think, okay, this might be something I want to investigate? Like, is there kind of like a criteria when you think in clinic, okay, this couple or this person sitting in front of me, we might need to do this test on them? Like, how do you decide? Does it happen to everybody or not?
So we don't do that test routinely on everyone because obviously it's an extra expense, and if it's not indicated, then it is not something we want to sort of run. If a patient's had recurrent miscarriage or recurrent implantation failure, those patients are definitely candidates for karyotyping. Some patients come to us knowing already that it's in the family. They may have an aunt or a sibling or an uncle that's had a translocation. So those patients definitely need karyotyping. So yeah, they are the main candidates of who we'd recommend it to.
So it's kind of the sort of repeat, those people, unfortunately, who've been on that, usually I imagine have been on a road for quite some time and been through either never getting pregnant. Is that right? You could just never, you've been trying and trying and trying, you've tried IVF and it's never achieved any positive result. Then you would think this is somebody we need to do this test on.
Yeah, it's actually more likely that the recurrent miscarriage, but I think if a patient has had quite a few repeated failures, then rather than continuing to do the same thing again, a karyotype would be quite a reasonable thing to recommend. They present with recurrent miscarriage, sadly.
Okay. And did I see something about secondary infertility as well? Did I read about secondary infertility and it being that being a flag?
Yeah, it's not unusual for a patient to come through and have a healthy live birth and then find out later that they've got a translocation, because you can generate normal embryos. And if you're lucky enough to get pregnant on your first attempt with a balanced or a normal embryo, then certainly those patients can later on realise that they've got a translocation.
Gosh, that's really interesting, isn't it? Because lots of people assume, you've had one healthy live birth, that therefore it will happen again. That's a very common kind of assumption, isn't it?
Yeah, I think unfortunately you do get a bit of you do think, well, I've had one, I'm going to be okay for the next one, and it can be just as hard, if not even harder, to sort of come to terms with the fact that you're struggling to conceive, I think.
Yeah. And so you just mentioned then, well, we were going to talk about PGT A, but you called it something different then. What did you say? What you said?
PGT-SR. So when we do any kind of testing that looks at the chromosomes, we either do PGT A, which is pre-implantation genetic testing for aneuploidy. So literally just looking at the chromosomes and seeing whether there's too few or too many. If a patient has a known translocation, so they know that they've got a structural rearrangement in their karyotype, then we do a process called PGT-SR, where it's very similar to the PGT-A, but we also look very closely at the chromosome, the area that we know has got the loss or gain. So it's a similar type of test, but just slightly different for the translocation patients.
Okay. And so PGT-A has become increasingly popular, especially, I don't know what it's like in how you feel about it, but in terms of what I've seen in clinic over the last 2 years, maybe the last 3 years, it just seems to be an increasing number of people coming through our clinic now choosing to do PGT-A. And so can you tell us a little bit about what that is, first of all, please?
Yeah, so the PGT-A testing, you would have a straightforward IVF cycle like any other patient coming through. And we will grow the embryos to day 5 or day 6 after egg collection. Those embryos that reach the blastocyst stage, which is the next stage of embryo development, we can take out between sort of 2 and 8 cells. We send the cells off for testing, and we freeze the blastocyst. The cells get sent to a genetics lab, who then can look at the chromosomes within the embryo and detect which embryos have got the right amount of chromosomes in, and those can therefore go on to be transferred, and it can detect the embryos that have got too few or too many chromosomes within it, and those embryos are not transferred. The research is very clear that those embryos don't go on to produce healthy pregnancies.
It's amazing, isn't it?
It's fascinating. I have to say, over the last 20 years, sort of my entry as a sort of 21-year-old embryologist to what we're seeing now, it's phenomenal, the amount of change, and it's really exciting to see where we're going to be in the next 10 years, because it's changing yearly. It's incredible.
And am I right in saying that the PGT-A testing is still from the sort of HFEA, so like the governing body that regulates fertility? Is it still considered a red light in terms of, it's like, they have the traffic light system, don't they, as to, this is kind of approved and there is enough robust evidence to say this is a viable test or procedure? Where does PGT-A sit on the traffic light system?
So unfortunately, PGT-A is still considered a part of the red light system for HFEA. A lot of the information out there is talking about previous kind of technology. So it's talking about day 3 biopsy, which was done sort of pre-2014. The techniques have changed a lot. So the data that's coming out now is suggesting actually in a certain group of patients, it can be really positive effect. But unfortunately, it is still a red light on the HFEA website.
And do you think that as more evidence comes out and with the new techniques that it's going to become green? Do you think it will change?
I think it will be a surprise if it goes from red to green. But I think definitely, I think it needs reevaluating and looking into, and certainly for a certain group of patients, it is definitely a very good tool to use.
So sort of following on from that, who would you sort of, at the Lister, who do you recommend? Do you recommend this test to people, or do you wait until patients ask for this test? Like, how does it work?
Yeah, that's a good question. So it's all patient sort of dependent. So the clinician will have a consultation with the patient and tailor a specific program and a specific protocol for that patient. So generally, it's not advisable for those patients under 35 because the pregnancy rates are really good in that group anyway. And the percentage of embryos that are abnormal in that age group are quite low anyway. So
what's the rough percentage? Sorry,
that's
all
right.
Do you have an idea of a rough percentage of 35 and below?
Yeah, so at 32 of the embryos that make blastocyst stage, we see about 15% of them to be genetically abnormal.
Yeah.
By the time it gets to 35, it's about 25%. So 1 in 4 of embryos of a blastocyst of a 35-year-old will be genetically abnormal. By the time you get to 38, it goes up to about 39%. And then at 40, it goes up to about 58%. And up to 74% by the time you're 42. So those stats show that actually after 38, it probably is something that will be beneficial for you, just to make sure that we're going to the right embryo straight away. Saying that, we have some patients that are under that 35 kind of age group that have had recurrent miscarriage, that have had an affected pregnancy, or just are really nervous and just want to know what the genetics of their embryos are doing. So we're very much of the sort of the thought process that it's informed decision. So as long as the patient understands what we're recommending, we're happy to sort of support the patient in their treatment.
So actually, to go through the process, so you do egg collection, fertilization, wait till you have embryos, then you take cells from the embryos, send
at
that one cell, is it?
We ideally sort of 5 to 8, but sometimes it, anything from 2 to 8 is fine, but usually around 5 cells. The embryo has to get to the blastocyst stage for us to be able to test them. And I think what a lot of patients are so surprised at is the drop-off rate along the way. So you may be lucky enough to get, say, 10 eggs, but not all of those are going to fertilize, not all of those are going to continue developing, and not all of those will make it to blastocyst stage. And that, in a way, is nature's way of filtering out some of those really genetically abnormal ones that don't get to that day 5, day 6 stage.
Yeah. And then, so I guess as for the person going through it, you are not going to be doing a fresh transfer because you are freezing everything, waiting for your results to come back in. And then from that point, you then would do a frozen transfer.
So some patients actually opt to have a fresh transfer of an untested embryo and then use the genetic testing on their excess embryos, just so that when they come around to doing their FET, they know, what they've got in storage and they know which one to go for first. And that, in a way, say if you've got 4 excess blastocysts, it does help you, instead of thinking, I've got 4 blastocysts, that's fantastic. It might be that 2 of those are genetically abnormal. So it gives you a bit more of a better management of your expectations, knowing, what you've got remaining in storage. But then other patients, perhaps that have had recurrent miscarriage or have had those affected pregnancies, they will do what we call a freeze-all cycle and not have a fresh transfer, test everything, and then wait 7 working days, up to 2 weeks for the results to come back, and then hopefully plan an FET after that. Yeah.
And so what, I guess the numbers that come back that are genetically normal, that varies depending on your age group.
It depends on your age group. And it can go cycle to cycle. We talk about statistics and we give our patients statistics, but sadly, some people won't meet that statistic. They'll be in the lower end, and happily some people will be in the higher end. And actually, it's not unusual for a patient to get all abnormals one cycle and to come through in the next cycle and get a good amount of normal embryos. So you have to be a bit cautious about sort of listening to the statistics, because it doesn't always sort of fit every patient.
So at what age do you let's say, ignoring everything else, if we're just talking age, at what age do you say do you recommend the PGTA? Is it 37 or 38?
37 or 38 and above is probably when we do have that conversation with them. We probably wouldn't talk to a patient younger than that about having it unless they suggested it. But, there is a lot of information out there and a lot of patient information. So if a patient is thinking about having PGTA, always ask your doctor if you want to discuss it. The doctors and the embryologist should be able to go through that with you.
And I presume I've completely forgot what I was going to ask you then. And it's just come back to me. I'm so happy when my brain does that. So let's say you have 5 embryos and on day 5, how do you, and so let's say the person is going to, they're going to transfer 1 and they're going to send 4 off for testing. How are you choosing which of those embryos to put back in fresh?
So at the moment we look and we select on a morphological sort of basis. So the embryo that gets to the advanced blastocyst stage first and is top quality. So when we grade embryos, we give them a number score of 1 to 6, and that is the stage of development. And then we give them 2 letters from A to D, with A being top quality. And the 2 letters, one is grading what we call the inner cell mass, which is the cells that go on to produce the baby. And the second letter is for the trophectoderm, which is the cells that go on to produce the placenta and all the placental tissue. So we pick at the moment the one that is morphologically effectively looking the prettiest. But the research shows and our work does show that it's not always that one that is the one that's chromosomally normal.
Yeah. And so what, at the moment, going through the clinic, what sort of percentage of people are doing PGTA testing? Is it ever increasing, or is it kind of still a smaller number of people actually doing it?
We, at the end of last year, about 25% of our frozen embryo transfers were PGT transfers. And this year, I think it's easily going to be up to about 40%, I think. So
wow. So it has seen a massive increase.
Yeah. And I think for those patients, especially those patients in the older age groups, it's the pregnancy rates are doing so well. So it's hard not to really think about PGTA as a good option for those patients when we are doing so well with the pregnancy rates for those groups.
So if you have a PGTA tested embryo, what is the difference in stats in terms of its success to go on then to be a healthy pregnancy and birth? What is the sort of difference between, let's say, I'll try and make it as easy as possible because I know I'm plucking stats. Let's say you're 38 and let's say there's one person who's had the best looking embryo transferred freshly, and there's another person who's had a PGTA tested embryo. What is the kind of difference in success rates? Can you do a comparison like that?
So I don't have the exact stats for a fresh 38-year-old, but for a PGT tested embryo at the moment in our lab, we're looking at around a 75% chance of pregnancy.
Wow.
And sadly, there's still going to be a group that does miscarry in that. So it doesn't guarantee you an ongoing pregnancy. But we're looking at around a 68% ongoing pregnancy rate, 70% at the moment. So that is higher than what we would expect for a 38-year-old having a fresh untested embryo.
And so the 25% of unsuccessful, why is that? Is that because the test has not been able to check for all the different genetic issues that might cause miscarriage? Am I right in that? Or
so the test is only 98% accurate. Any genetic test out there is never going to be 100% accurate. So there is that very small risk of a misdiagnosis. There are lots of other reasons that people aren't getting pregnant. So there might be endometrial issues, which I know investigating the endometrium is one of your hot topics. It might be that the embryo, although at the time we thought it did survive that freeze-thaw process, once we transferred it back, perhaps it actually didn't survive as well as we thought. So that might be one of the reasons why these patients don't get pregnant. And yeah, there might be something else going on at a different level that we don't know about. So as I said, that genetics has expanded so much in the last 5-10 years, but I'm sure in 10 years time, there'll be a group of patients that we look back on and think, oh, that's why they didn't get pregnant. It's changing so quickly.
Yes. And so, because that's one of the things when I've sat with people and they've been talking about it in clinic, some people have sort of got this, they've been told that the risks of doing the test is too great. Like there's risk of damage, there's risk of it not working. Is that, and it sounds like that's why the HFEA it was a red light years ago.
Yeah.
Is that still the case, or is like technology moved on that's much less likely to happen? Because I guess with any, it's human beings doing testings, and human beings all there is always room for error.
Yeah, so there's always going to be a risk of damage with every extra step you do to the egg and embryo. The risk of biopsy in our clinic is less than 1%. So there is a very small risk of damage. It is there, but it is quite low. You've also got the risk of the freezing process. If a patient's going to freeze anyway, that risk is still going to be there. So looking at our stats at the moment, we've got about a 97% survival rate. So there is a very small risk of damage to the blastocyst with the freezing process.
And the other thing is that a lot of people say if you've got like 1 or 2 embryos, say you've done around and that's kind of where you've ended up, lots of people are told, well, it's not really worth doing the testing if you've only got 1 or 2. It's better to do a transfer. Is that is that the
that's a good question actually, and that's very patient dependent. Some patients if they're young and they've got no history, then if they've only got 1, then perhaps it is best to transfer it rather than charging them the extra for the testing and then charging them the extra for the frozen embryo transfer that they'll have to have. But equally, if we've got a patient that's only got 1 blastocyst but has had a medical termination for an effective pregnancy, or has had like quite a few miscarriages, then certainly I think it's definitely worth thinking about the PGT to get the answers, to see and to give them the confidence, a bit more of confidence in the embryo that's being transferred.
Yeah, we have lots of people that I see who just want to do everything they can to minimize the risk of miscarriage and that heartbreak of having to go through that when it wasn't going to be successful because the genetics weren't right. And it's if you can avoid that, if there's an option to avoid that pain and heartbreak, then it makes total sense, doesn't it? That you do that.
Certainly for those patients, then genetic testing is a really good option for them.
And am I right, is karyotyping or PGT A, is it only in private clinics, or is it available also in NHS clinics?
So karyotyping, I'm not sure whether you can get that done on the NHS. Certainly if you've got a history, if you've got a sibling, then your GP should be able to run that test for you. PGT A testing for sort of aneuploidy is mainly in the private units. I think it's not a treatment that the NHS offer unless you've got a specific condition in your family, or unless you've got a specific gene disorder in your family. So, for example, if you know that you've got cystic fibrosis in your family, or you're a carrier of muscular dystrophy, or not a carrier, if you have muscular dystrophy, then that treatment is available in the NHS.
Do you think it will move to be more mainstream in the future? Do you think as kind of the world kind of moves on and the I don't know, do you think it will become more widely available, more widely used?
In the NHS units, or?
In the NHS unit.
I don't, sadly, I think with the way the funding is going, I can't see that happening in the near future, but I don't know. What's going to happen in the future.
So just to finish off, actually, how much does it actually cost to do? So say if you want to do PGT A testing, are you charged per embryo, or how does it work cost wise?
So it's different. That the costing is slightly different in different units. So some units will charge you for a certain amount. There's a sort of a one package charge for up to 7 or 8 embryos. At the Lister, we charge per embryo because we don't want a patient that's only got 1 or 2 embryos to pay the same as a patient that's fortunate enough to get sort of 6 or 7. So at the moment, we charge £500 per embryo. And then obviously you have to pay for the freezing on top of that.
Okay, great. Thank you, Kathryn, for all
My
that
pleasure.
information and help. If people want more information, where would you where would they go to read about it? Where can they find out more information?
So the internet is a massive thing, so I'd always be a bit wary of going to the internet. But a lot of the major clinics that offer the testing have got a section on their website about the PGT testing. A good unit will be happy for a patient or a prospective patient to ring up and have a chat with them about it. So I always say, don't forget about the embryologist. Give us a call if you've ever got any questions or you're ever worried. Always give us a call and have a chat with us, because we're happy to talk to you all.
Yes. Information, as we always say, is power, isn't it, in this situation?
Yes,
so I think
exactly.
do
all about
research,
decision making.
Yeah. Well, thank you very much, Kathryn, for your time. As always,
Thank you.
It's lovely to see you.
Always lovely to speak to you.
Oh, thank you. And I will put all the information on the show notes if people want to find out more about what we've been talking about today. So thanks a lot, Kathryn, and we'll hopefully see you soon.
Hopefully, yes. Thank you, Hannah.
If you've enjoyed listening to this and want to find out more, then come and join my free community in Facebook. We have loads of resources. You can catch up on all our previous webinars and be the first to know about forthcoming events. To sign up, just follow the link in the show notes. And if you'd like to work one-to-one with myself or one of the team, then please see our website, hannahpern.com, where you can book in directly or organise a discovery call to find out how we can support your fertility and your reproductive health.